All right, students, so it turns out that my Panopto also was not working, so I had to use my computer to record this, and I'll make a YouTube video out of it. So that will actually be easier for you guys to access anyway. For those of you who had me in the morning, we're also going to, I lost my train of thought. We're going to start from the very beginning because I'm also going to play this video for the students that are coming in the afternoon. I don't want there to be any more problems, and also I just always want you guys to get the same information, okay? So this is chapter 7, and we're going to talk about periodontitis. As I said, moving forward in all these chapters, I want you guys, for the next few chapters, I want you guys to please also make sure that you're referring to this little cheat sheet that I made for you guys, because it will be very helpful. I hope it will be helpful for you guys. So please have it handy, because I'm going to be referring to it back and forth a little bit. So here we have the main category that we're dealing with now is periodontitis. And necrotizing periodontal disease we have already identified. You guys know what that is, so we're not going to discuss that any further. And periodontitis as a manifestation of systemic disease is actually covered in one of the upcoming chapters in your textbook. Chapter 16, the name of that chapter is Systemic Risk Factors that Amplify Susceptibility to Periodontal Disease. So we'll talk a little bit more about that classification when we get to that chapter. Periodontitis, a little background information on periodontitis. It's the #1 cause of tooth loss in adults, equaling to about 47% of adults over the age of 30 in the United States are suffering from periodontal disease. We know it's initiated by bacteria, and it causes progressive destruction of the periodontal ligament and the supporting alveolar bone. You can have periodontitis at any age, but it is more common over the age of 35, and it usually progresses at a slow to moderate rate. Again, it begins as plaque-induced, bacterial-induced gingivitis that has progressed to periodontitis, and plaque-induced gingivitis is reversible, but chronic periodontitis is not. Here we have a really good picture showing us, illustrating for us what it looks like when we have bone loss. Now, if we're just looking at, if we're just looking at this picture, I don't have a pointer when I do this, but I really do like to see the full picture. When we have, in this picture, you see, you can't tell if it's periodontitis by looking at the picture, which is why as I go through this, I'm going to tell you time and again how important it is for you to be able to have a full periodontal assessment in order to really be able to identify periodontitis. You cannot just look at the tissues, even though looking at the tissue in a gingival description is so important. For sure, I can't just look at this tissue and decide if it's gingivitis or periodontitis. The illustration that you see is showing us quite a few things. The first thing that we see, of course, is the bone loss. And just look at the lower right. I wish I could point, but the lower right, the writing here on the right-hand side of this slide shows bone loss. And where it's actually connected to is the alveolar bone. The smaller little connection is the alveolar bone, the crestal bone. It's trying to show you like a specific cross section, showing you a cross section of the tooth, and then it's also connected into the bone that surrounds the tooth. The next up is that we see that there is connective tissue destruction. We have destruction of the periodontal ligament fibers and also the gingival fibers. We have a periodontal pocket, which means that we see a separation of the sulcular epithelium. And then, of course, we have apical migration of the junctional epithelium. Those are all signs of periodontal disease. You may see references in the literature to chronic periodontitis, aggressive periodontitis, and localized juvenile periodontitis. These are the older terms. The older classification system used these terms. And when we began this conversation, I showed you all the old terms, the old classification system. I'm really thinking of giving that to you guys in as a hard copy, giving it out to you in clinic so that as you guys are working through clinic, you can just kind of get used to the old classification system. I don't want to confuse you, but it's my understanding that you guys also have to be able to compare the old with the new classification system. And in private practice, unfortunately, dentists and other professionals in private practice have not really warmed themselves up to this new classification system. And I think that even by the time you guys graduate, you will have to deal with this, with using the older terms. As opposed to using the new classification terms, as we should be doing. So through our discussions and from even having gotten this far in the program, that the signs and symptoms of periodontitis include reddish to purplish tissue or tissues appearing pale. And remember, we spoke about tissue being fibrotic. And when tissue is fibrotic, there is no blood flow. That's why the tissue appears so pale. You will have gingival bleeding, loss of attachment, which leads to mobility, and then, of course, tissue edema and suppuration. The patient may complain. Usually, actually, in my experience, the patient is complaining of bleeding. They happen to notice bleeding. Unfortunately, many people, though, feel that the bleeding is normal. Also, patients may complain about red, swollen gingiva, bad taste in the mouth and bad breath, sensitive teeth, loose teeth, and every once in a while somebody will notice that there is pus coming out of that area. And we also know that there's alterations in the color, texture, and size of the gingival margin. The color will appear reddish purplish, or on the other end of it, it'll appear very pink. We will have changes in the gingival margins. They'll appear rolled, and then we may also see some flattened papilla. However, as important as a gingival assessment is, and as important as it is to be able to identify those changes, the clinical appearance is not a reliable indicator of the presence or severity of chronic periodontitis. Chronic periodontitis may exhibit pronounced changes in appearance, and it may also exhibit minimal changes in appearance, which is why, again, it's so important for us to do a full periodontal assessment. We don't diagnose periodontal disease just from looking at the gingival tissues. Here's a great example. We can all agree that this is, if not periodontitis, for sure, this is a gingivitis. Lots of changes in tissue consistency and shape and texture and location. However, here, none of us would really say to ourselves, wow, this must be a perio patient. Whereas over here, we can definitely recognize that something is happening. At the very least, gingivitis is happening. We cannot say the same for this picture. If the gingival tissues are looking pale pink, you're looking for firm fibrotic tissue, and you should definitely check for attachment loss. So what it's telling you is that if you see a patient like this at any point in time, I'll be honest with you, this tissue doesn't necessarily look fibrotic to me. I do see some areas of redness there where I say, okay, there is some blood flow flowing here. But the message, what they're trying to tell you, what the textbook is trying to tell you, is that you definitely need to pick up a probe and insert the probe and to see if there is any type of loss of attachment or periodontal pocket death. This is a great image. The clinical appearance of this tissue looks really fabulous, maybe a little kind of pale pink, but once you insert the probe, you see a very deep pocket there. And assuming this is a 12 millimeter probe, we're looking at an 8 millimeter pocket. Gingival bleeding and crevicular fluid. Gingival bleeding is common in periodontal disease. It can be spontaneous or in response to instrumentation. And increased flow of crevicular fluid and pus from pockets is something that we will see in periodontitis. I've spoken to you a couple of times about how I treat for certain. Whenever I have had a patient who has pus coming out of a periodontal pocket, I really am super extra diligent about making sure that I clean that area out very thoroughly. And sometimes I will clean the area out and I will lavage it afterwards with some hydrogen peroxide, sometimes after I instrument the area. And by instrument, I really mean root planing. Periodontitis requires root planing, smoothing out the tooth structures. Also sometimes a curettage that we do that we're technically not supposed to do, but sometimes you can't, you're not intentionally doing a curettage. It's what happens as a result of instrumentation. And so when I say instrument, I mean root planing. And sometimes I'll just put, after my root planing, I will put what's called a localized antibiotic. Usually Arestin is what I use. So I think probably Professor Raymond will be talking to you a little bit more about Arestin. But it's a very effective localized antibiotic. Now, bleeding in response to probing. So what we're seeing here is obviously the probe is going in. I like this picture a lot because if you look at where the blood is, I kind of feel like I see some pus coming out of there. Now, I see that all around the cervical portion of the tooth, there is some biofilm, right? We see some white plaque developing there. But I really do feel that the bleeding has a little bit of white stuff in there, and I really feel like that white stuff may even be pus. When pus is coming out of a pocket that is also bleeding, they do not mix together. The pus does not mix together with the blood to cause a pink fluid. What will actually happen is that you will see the blood coming out, and you'll see like a very milky white fluid as well. And you'll know that that pocket is actually bleeding, and there is pus there as well. And sometimes, you can even just press on the side of the tooth and squeeze the pus out. And that's what this image is showing you, that pressure with the clinician's finger on the gingiva can reveal some exudate, but the better word is pus, which means purulent exudate. And that is a very effective teaching tool for patients. Patients are not really, when you say, okay, you have pus coming out of the tooth, it's never as powerful as for the patient to really see the pus coming out of the tooth. And clinical attachment loss. So now here is the hallmark of periodontal disease. It can occur in one site of a single tooth or several teeth or the entire dentition. With clinical attachment loss, we have apical migration of the junctional epithelium. We have destruction of the fibers of the gingiva and also destruction of the periodontal ligament fibers. So both the gingival fibers and the periodontal ligament fibers are taking a beating. We're also going to see loss of alveolar bone from around the tooth. Progressive bone loss may result in tooth loss. Furcation involvement becomes more evident because as the bone migrates apically, now it exposes these furcations, and we also will probably start seeing some tooth mobility and or drifting. I know this image is very, very dark. It's very hard to see, but this is a actually great image of bone loss happening. And I wish I had a pointer to show you where it is, but certainly this bone loss would be at the very least the middle third of the tooth, and some of us may even be saying, okay, it's really happening at the apical portion, and that is some severe bone loss. We're going to talk a little bit more about, actually, we're going to do this right now. I have some pictures here from the internet that I wanted to kind of use to go over this issue of estimating the bone loss, because you are going to have to estimate the percentage of bone loss that a patient has in order to properly calculate the grade portion of the staging and grading. So let's start with this tooth, and we're going to start with tooth that we're going to call this, I think in the other group we decided to call it tooth number 2221. And this is the premolar that I'm looking at. Oh, I can point now. Okay? And I want you to look at this tooth. Here is the CEJ. When we calculate bone loss, we're going from the CEJ to the very tip of the apex. So from the apex to the CEJ, in terms of percentage, tell me how much percentage bone loss this tooth has at its worst part. Because if you can see, there's more bone loss here than there is here. Right? So you're kind of really looking at this distal portion of this tooth. Okay? And in the other class, we really decided that this was looking more like a 60% bone loss. And I was happy with that. This is what I would call this. Okay? This tooth has 60% bone loss. And then I have another image here, and I kind of just want you guys looking here. Don't look over here, because obviously somebody wrote all over the place. I think what the person who did this was trying to make the line of where the bone loss is, and so you see how it's not really, it is horizontal bone loss, but it's really kind of erratic. It's not completely straight across. And this line, I'm going to assume, is showing the other part of the bone loss. This is what I'm assuming. This is what I think it's doing. So you have facial bone and lingual bone. Think of it that way. You don't know if it's facial bone and you don't know if it's lingual bone, but for certain we have a layer of bone here, we have a line of bone here, and then we do have a more fainter line of bone loss here, of bone here. You see it on this picture. Okay, so let's start in the back. So we see that there is some bone here. There's definitely bone here. Very faint white bone here. And then we kind of, I lose it anyway here, but then I see it coming back here. I don't really see here. For me, this is all bone loss. but you see a kind of fainter version. And then you also see another line of bone loss that kind of starts here as well, and then it kind of just goes up. Okay, you see that radiolucency there, and then you kind of see it here again. Okay, and then it's kind of going up here, and then it does a little weird Italy thing here where it comes down like Italy the boot does in a map, and then it's coming all the way here and coming down. So this image is just showing you whether it's the buccal or the lingual bone, it's just showing you different levels of bone. Having said all that, I want you to look at and I'm going to go ahead and say this is the upper left, right? So this is 16, 15, 14. And I want you to really tell me at the worst portion, at the most severe level of bone loss, how much bone loss this tooth has. This is tooth number 15. How much bone loss does this tooth have at its most severe portion? And you're going to tell me 10%, 20%, 35, 80, whatever you think the percentage of bone loss is. Okay, and I will tell you that I would also put this somewhere around 60, maybe even 70% of bone loss, because the apex of this tooth is right here. Here is the apex. Okay, so if you said 60 or 70, that's good enough for me. I just want you to see how severe that bone loss is. And then if we came over here, let's go ahead and just for fun, pick out the bone loss here. Tell me how much percentage of bone loss we have at the distal of tooth number 16. Understanding that here is my CEJ right here. This is my CEJ right here. Okay? So I would put this bone loss here at maybe 15, 20% bone loss. This bone loss is not so bad on the distal of that tooth. Okay, and then we're going to do one more. And right now you're going to be looking at tooth number 19. I'm calling this 17, 18, 19. And I want you to tell me on tooth number 19, what is the percentage of bone loss at the worst, at the deepest, worst level? What percentage bone loss do you have here? Okay, and for me, the worst is here. Okay, this is a little bit worse than the mesial portion, and this is about 30% bone loss. And this is, you see how I'm doing it, there's nothing fancy. Back in my day, we used to take a ruler and actually measure these things, but now you're asked to kind of just eyeball it, to kind of just see how much bone loss there is. And always taking into account that the length of the root is obviously different in all teeth. Sometimes you'll see smaller roots, sometimes you see longer roots. This looks like a very long root for a premolar here, and that's why we really kind of have to just look at each individual tooth and estimate the amount of bone loss we have. Okay, so let's go back to our PowerPoint, and I guess I'm going to stay here. It's actually easier if I stay. I can't be without my little pointing thing here. And once again, these images are showing us that the just because a tissue looks a certain way doesn't mean that there is no disease there. So to be honest with you, this looks very fibrotic to me. This is extremely pale pink. So this tissue would really would call out to me. I would say, okay, let me make sure that there's no pockets here. And this is almost a 12 millimeter pocket. It's a very, very deep pocket. Even though the tissues look great, it's a very deep pocket. I love this image very much because I keep talking to you guys about periodontal surgery, about flap surgery, and this is an image of flap surgery. So you are looking, this is actually very severe bone loss, but right here is the gingiva that has been cut away. They literally take a scalpel, they sneak it underneath the gingiva and slice all the gingiva away from the bone, and then they flap it. And if you want to know what a flap is, take your upper lip with your 2 fingers and pull it up, okay? And if you pull it up and are showing kind of like the labial mucosa, that's what a flap is. It's just flapping it up. And this is what periodontal surgery looks like. When you do a flap surgery, what you're doing is cutting that away, lifting it up so that you have access to the root surface. And what they do is they clean this whole area out with scalers, with an ultrasonic. It's really very savage when you see it. It's like, wow, what are you people doing? And then they will, nowadays, they really pack some bone in there, some cadaver bone, and then they will take the flap back down and stitch the whole business down. So that's a good image. So we also know that there's lots of contributing factors, right? Environmental factors such as smoking, systemic factors. If you are compromised systemically because you have a disease such as diabetes or HIV, then Obviously, you know that you are immunocompromised, and that will affect healing, obviously. And genetics also, we're going to talk about, we're also going to talk about this in neuropathology as well, but there are some genetic disorders that are known to cause very severe periodontal disease. So no amount of brushing and flossing is going to help that patient, even though we do educate that patient and try to keep it from getting worse. Genetics, if you have one of these genetic disorders, you are guaranteed that you're going to have this periodontal disease. And then, of course, we're going to talk a little bit more. We've already talked about some of these factors in oral microbiology, but we will talk more about issues such as tooth crowding or overhanging restorations. And this issue of absence of pain is really something that makes our lives, makes this a little more challenging. Dealing with periodontitis becomes more challenging because our patients are not in pain, and so it's very difficult for them to perceive the severity of the disorder if they're not in pain. And this is what this is saying. This is what this is saying, that people do not seek treatment early in the disease and also don't follow up with treatment because they're not perceiving, they don't have pain that's really motivating them. We're going to talk about the extent. So now when we classify periodontal disease, we always have to talk about the extent. That means that you always have to tell me how much of the mouth is affected, how many teeth are affected, where are all those teeth that are affected. And so we use these terms localized and generalized to talk about the distribution of disease throughout the dentition. And it's going to be characterized by the percentage of the affected teeth. So that localized could mean two things. It may involve one site or a single tooth or several sites on several teeth, right? Like it's happening in an area. Or we can use localized to refer to 30% or less of the teeth. 30% or less of the teeth. When we are classifying periodontitis, it is localized, is less than 30% of the teeth are affected. Okay? This is going to be a little different than when we talk about classifying other things, because remember when I talked to you about when we were doing the probing depths and then we had to divide the probing depths, we did that last week. It's different. And now I'm talking to you about classifying periodontal disease, and we're going to go by teeth. In that scenario, we're going to go by teeth. And generalized refers to more than 30% of the teeth, or when we want to say that most or the entire dentition has been affected. Disease progression in untreated periodontitis is usually a slow, continual process. There are periods of remission or exacerbation, and in a limited number of individuals, there is rapid progressions, and it could be 4 times as fast, of destruction of the periodontal ligament and supporting alveolar bone. Tissue destruction in untreated periodontitis does not affect all the teeth evenly. You're going to have some teeth that are going to have more bone loss, less bone loss, more calculus buildup, less calculus buildup, more bleeding, less bleeding. It doesn't progress the same. You would think in the mouth it would affect all the teeth the same, but it does not. So it can be site-specific. Rapidly progressing disease occurs more frequently in interproximal areas that have heavy deposits. Once again, underscoring the importance of calculus removal, but please always remember that the severity of the immune response is going to be dictated by the person, by the health of the person. So let's do some before and after periodontal therapy. So this is before our first patient here, and of course you see all this inflammation here. Not quite so bad here, but remember that we can't really just use a radiograph to tell us how bad the periodontal disease is. And this is afterwards, so for sure here we see some nice healing after periodontal therapy. And I'm not sure if these pictures are periodontal surgery and scaling and root planing. They don't tell us specifically. Here is another case, much easier to tell. Lots of calculus here. I'll tell you that tissue looks like that because there's tons of calculus there. And of course we have all this redness and inflammation in all the other areas. And after we do this, our periodontal therapy, we see a great healing. This looks really, really great. For my taste, still a little bit red here. I still don't like it, and I still feel like I see some plaque buildup here as well, but certainly much, much better. And here's our third patient. This patient has a huge overbite as well, by the way. And the area that I really see that's jumping out to me here is the upper right. Again, I don't have periodontal depth, so I don't know if he's got periodontal bone loss and loss of attachment anywhere else. But for sure here, I see some redness happening. And then afterwards, we see a huge improvement. And I don't know if they fixed his bite as well, but certainly you don't have the same deep bite as you have there. Okay, so the therapeutic endpoints of periodontal therapy. What is it? Why are we doing this? Why are we doing all the things that we do? Home care and scaling and root planing and maybe even perhaps surgery. Well, we want to eliminate microbial etiology and contributing factors that perpetuate inflammation. This word eliminate, I really would cross out and I would say significantly reduce, because you know that you can never remove all of the microbiota. The microbiota is permanent in a person's mouth. You're not going to kill all the bacteria in the person's mouth. Preservation of the state of the teeth and periodontium in a state of health, function, and stability, and prevention of disease recurrence. We just want those tissues to go back to their normal, healthy state. Treatment modalities focus on, so modalities refers to what are we going to do? Okay, what is it exactly that we're going to be doing? So we want to, of course, the number one thing is focus on reinforcing daily self-care. This is brushing, flossing. I've said this to you so many times, how important home care is in the prevention of periodontal disease and also in maintaining. A patient who has had periodontal disease and has gone for treatment must maintain healthy condition, and the best way to do that, the most effective way to do that, is by mechanical biofilm removal on a regular basis. So we do that. So the first thing that we do is, and it's very important that we do that, is make sure that we reinforce daily self-care routine. Secondly is periodontal instrumentation to remove microbial etiology. So that means that I'm actually picking up my instruments and I'm removing the biofilm. Okay, biofilm, remember, is most important at the bottom of the pocket. Okay, it's most important for us. That's where all the disease is happening. The disease is not happening along the marginal, along the margin of the gingiva. It is happening at the base of the sulcus. We eliminate local intraoral factors such as overhangs, such as calculus. Technically, calculus is calculus affects periodontal disease, exacerbates, progresses because it is something that the bacteria can hang on to. It makes it much easier for bacteria to form biofilms if they have a rough surface such as calculus to hang on to. Periodontal surgery, if it gets really bad and those pockets are usually anything after 6 millimeters, periodontists will do surgery on. And the intent of the surgery is to reduce the depth of the pocket. And here I really literally want you to imagine the pocket that's in your blue lab coats, right? You have a pocket, and imagine cutting it in half. You're making the pocket much smaller. That's exactly what they do in periodontal surgery. And then, of course, they have to adhere to their maintenance regimen. Anybody who has periodontal disease at this point, I'm very comfortable with saying, you have to come in every 3 months. I have to take a look at you. Because what ends up happening is that if that recall goes too long, then it starts the process up all over again. Recurrent form of periodontal disease is a return of destructive periodontitis that had been previously arrested. Anyone with a prior history of disease is at risk for recurrence, and it happens especially. So it's pretty much exactly what I just said here. They have to adhere to the perio regimen because otherwise the disease will come back. Usually it will come back. It's not something that you heal, that you cure. It's something that you have to stay on top of. And the easiest way and the most effective way to stay on top of it is by practicing good oral hygiene so that you don't initiate an immune response. Okay. A periodontitis case. So now this is it. So now we're going to talk about how we're going to do our staging and grading. And the first thing that we need to do is to decide if a patient is a periodontal case or not. And remember now, go back to our little cheat sheet, and remember that on our cheat sheet, the very first category we have is periodontal health, gingivitis, and gingival conditions. And remember that we also have those categories of periodontal health, gingival health periodontal health, yes, on an intact periodontium. We have periodontal health on a reduced periodontium, and we have periodontal health on a reduced periodontium of a stable patient or a patient of a stable periodontitis patient or a patient that had never been treated for periodontitis. So we have very specific classifications underneath this heading. And the next heading that we're going to deal with is periodontitis. So these are these patients that we thought that probably have some kind of gingival redness and all the characteristics of gingivitis. But once we bump a patient up to periodontitis, we notice what? We notice that there is clinical attachment loss, some level of loss of attachment. Okay, so a patient is a periodontitis case if there is interdental clinical attachment loss at 2 or more adjacent teeth. Okay, a patient is a periodontitis case if there is interdental clinical attachment loss at 2 or more non-adjacent teeth. That is your definition of periodontitis in terms of classification. How do we classify them as periodontitis? If there is interdental clinical attachment loss at 2 or more non-adjacent teeth. I'm sorry, I think I said adjacent before. 2 or more non-adjacent teeth. So 18 and 22, 24 and 29, but it can't be 24 and 23, and it can't be 18 and 17. They have to be non-adjacent. Or we can have facial or lingual clinical attachment loss of 3 millimeters or more, with pocketing greater than 3 millimeter detectable at 2 or more non-adjacent teeth. And we're going to go over this a little bit more. I know this is a lot, but it will make sense as we go ahead and start doing our thing. Okay? Attachment loss cannot be due to non-periodontitis causes, such as gingival recession of traumatic origin, dental caries extending to or apical to the CEJ, the presence of clinical attachment loss on the distal aspect of a second molar associated with extraction of a third molar, endodontic lesion draining through the marginal gingiva, or if the tooth has a vertical fracture. What this is telling you is that there is a reason for the periodontitis that has nothing to do with biofilm. Essentially, this is what they're telling you. Okay? So a patient will have periodontitis if they have these qualifications, but not if my patient has interdental attachment loss at 2 or more non-adjacent teeth due to caries present on those teeth. Okay? And then we have 3 forms of periodontitis that we're talking about. Remember that I said we're not talking, and this here, the 3 forms of periodontitis are also in our cheat sheet. Okay, necrotizing periodontal diseases, periodontitis as a manifestation of systemic diseases, and periodontitis. Remember that we already talked about necrotizing periodontal diseases, and we're going to talk about this category of periodontitis as a direct manifestation of systemic diseases in the upcoming chapter. I believe it's chapter 16. So the 4 stages of periodontitis. This is it, people. So we're going to identify periodontitis. We need to talk about extent. Remember, extent refers to localized or generalized. We need to give our patient a stage, and we need to give our patient a grade. So, stage at presentation of periodontitis is defined by the severity, how many of the sites are affected, and complexity of management. I'm going to explain this a little bit more. But the first thing I want to do is go back to my other sheet, to my cheat sheet, and show you where you're going to find this on the cheat sheet. So you're going to find anything related to periodontitis on page 4 and page 5. So I'm going to scroll down to page 4, and there is all my specifics related to periodontitis. Again, we're not covering this one. We're not covering manifestations. All we're covering right now is this one, periodontitis. Okay, and the same qualifications that were there, that were on the PowerPoint, are here as well. Okay, clinical attachment loss at 2 non-adjacent teeth, and stage and grade we're going to go into right now. Staging refers to the severity of the condition. How bad is it? And we have these 4 stages of periodontal disease: stage 1, stage 2, stage 3, stage 4. And at each stage, we're looking at a few things. We're going to be, in order to identify and to say what stage the patient is in, we're going to be looking at these 4 things. The first thing we're going to be looking at is interdental clinical attachment loss. How am I going to get that information? Where do I have the information about the interdental clinical attachment loss? Well, it's in our probing. Okay, so to get this, you're going to go into the patient's probing, and you're going to be able to see the gingival margin, and you're going to be able to see the periodontal pocket depth alongside with your radiographs as well, and you're going to be able to see exactly how much loss of attachment. This is not referring to periodontal pockets. It's not telling you how deep are the pockets, although that will come into play in a little bit. It's asking you how much interdental clinical attachment loss is there. In stage 1, it's 1 to 2 millimeters. In stage 2, it's 3 to 4. And in stage 3 to 4. And in stage 3 and 4, it's more than or equal to 5 millimeters. The next thing in the staging that we're going to have to identify is if there is radiographic bone loss. And this is what I was showing you guys before with the radiographs. We need to know if it's at the coronal third. The coronal third refers to the amount of bone loss closest to the crown of the tooth. That is the coronal third. So for stage 1, we have radiographic bone loss that is less than the coronal third, less than 15% of the of bone loss belongs in stage 1 category. If it's at the coronal third, where it's up to 30%, the coronal third is up to 30%. That's why it's third, right? 30, 60, 90. So now we're saying, and it's actually going to 33% is a better way of saying it. Actually, I should start saying that, 33%. So in stage 2, I know that I have bone loss that is that is less than 33% bone loss. So remember, I don't know if I still have those here. Here, okay? So I said that this is, like about 30% bone loss? Okay, this is showing me definitely 30, let's call it 33. I need to get comfortable with that. 33% bone loss, and if it has 33% bone loss, then I know that I am in stage 2. Stage 3 and stage 4, it's extending to the middle third of the root and beyond. Okay, so anything more than 33% bumps my patient up to a 3 or a 4. The next thing I need to consider is tooth loss due to periodontitis. And this information you will get from your patient. Okay, so you're going to ask your patient, if your patient is missing any teeth, you're going to ask them why they're missing their teeth. And if they say, oh, I had a root canal and the root canal went bad, then that does not count. This only counts if they lost the teeth due to periodontitis. Okay, and then the next one is kind of the hardest one to understand, and it involves complexity. Okay, and complexity means that there are other factors that we need to consider when we're putting our patients into these stages. So stage 1, if my patient that has less than 4 millimeters periodontal probing, now I can really just rely on my periodontal probing, then he really belongs in stage 1. Okay, and additionally, my patients in stage 1, perio, really have mostly horizontal bone loss. In stage 2, we have maximum probing depths equal to or less than 5. And again, mostly horizontal bone loss. And now when we get to stage 3 and 4, we have more complicating factors. Now my probing depths are more than or equal to 6 millimeters. I do have some areas of vertical bone loss. I may have a class 2 or a class 3 furcation. And moderate ridge defects refers to bone loss. There's no teeth. A ridge is an edentulous ridge. There's no teeth there. And stage 4 stage 4 to me in my mind is the easiest to identify because now my patient is really in trouble. In addition to all this stuff happening here, my patient needs complex rehabilitation due to masticatory dysfunction. We have occlusal trauma. We have severe ridge defects. We have bite collapse. My teeth are shifting and moving, and this is the most severest stage. This is the worst stage of periodontal disease. And don't forget, you always have to tell me about the extent and distribution, if it's localized or if it's generalized. And also we have this designation here, molar incisor pattern, which I'll talk to you a little bit more about when we meet together. Okay? Remember that we're going to meet together on Tuesday. We're going to do 3 case studies together so that you will be able to classify this. We'll work on this together. Okay? In addition to the staging, we need to talk about the grading. Okay? And the grading indicates the rate of periodontitis progression. I really feel like the grading is a little bit more difficult to kind of wrap your head around than the staging. Okay? Because the grading is telling me, what the grading is trying to do, it's telling me how quickly this disease is progressing. But if I'm only seeing my patient for the first time, it's impossible for me to figure out how my patient is progressing. This is the first time I've seen him. I have nothing to compare it to. But the creators of this classification system actually came up with an answer for this, and so I'm going to show you what the grading system is. But the grading seeks to identify progression. How fast is this progressing? And we know that periodontal disease does progress a little bit quicker in some patients, and I'll explain that to you now. The 3 grades that I have are grade A, B, and C. For the most part, your patients are going to start out in grade B. Okay, and that's directly from the creators of this classification system. Your patients, if you don't have radiograph on your patient, or if you don't have radiographs that you can compare to anything else, you're going to start out with your patients at grade B. It's a moderate rate. Most people, and this corresponds to most people being at a moderate, periodontal disease progresses at a moderate rate. And essentially what this means is that if I have direct evidence of radiographic bone loss or clinical attachment loss, you may not have direct evidence, because direct evidence really refers to radiographs and a full periodontal assessment. So let's say if you work in a really great dental office and the patient's been coming to that office for 5 years, you have radiographs at the 5-year mark, you have radiographs at the 3-year mark, and now you have radiographs again that you can compare. But that doesn't always happen, right? And then sometimes you do have the radiographs, but they're of poor quality. Okay, this is when I also talk to students about how important it is for you to be taking really good radiographs on your patient. Because if the radiographs are not poor quality, it's really going to affect the way that I can diagnose periodontal disease. So if there has been no loss of no loss of bone or no clinical attachment loss, it's a slow rate of progression. If there has been less than 2 millimeters of loss, it is a grade B. And if there's more than 2 millimeters or equal to 2 millimeters of loss, it is a grade C. However, they came up with a different way of calculating progression as well. And this comes about by calculating the percentage of bone loss divided by the age. So if you do not have direct evidence of radiographic bone loss, you are to use this method of ascertaining the progression of this disease. And how do we do this? Well, we take the percentage of bone loss and we divide it by the age. So let's go back to this x-ray right here, and I'm going to tell you that this person is 50 years old. And we decided that on this patient, this is about 30% bone loss. So you're going to take 30 and you're going to divide it by 50, and I'm doing that right now on my calculator. And 30 divided by 50 is 0.6. So I go back to my little chart, and this is why I say this little cheat sheet will come in handy. 0.6 is here, grade B. So 0.25 to 1.0 is grade B. So once I do that math, once I take the percentage of bone loss and divide it by the age, whatever number I come up with, I'm going to look into my little chart and see which grade it fits into. Let's go ahead and do another one. Let's make believe that this patient here is 25 years old. We have 30% bone loss, and he's 25 years old. That gives me a 1.2. And if I look in my chart here, I see that that is greater than 1, and that means that my patient is in a grade C. Again, don't go too crazy as you're watching this. I get it that it's a little confusing. We're going to do 3 of these together in school next week. Also, additionally, we're going to look at the case phenotype. What does this look like in the mouth? Because these grades that we're giving here, you can bump up or you can bump a patient up to a different grade if they are showing some of these signs. So if we have heavy biofilm deposits, okay, this is my patient who comes in, he's got tons of stuff everywhere, but he's got gray bone, okay, he would be a grade C. A grade A. If I have somebody coming in that they have some bone loss and they do have some calculus and they do have some biofilm, well, that's kind of commensurate with, the destruction is commensurate with the biofilm. It means, okay, it makes sense. And however, on grade C, I'm seeing a lot of destruction in a patient that really has hardly any biofilm and really has hardly any calculus and any deposits in the mouth. And therefore, that's a grade C. Okay. Additionally, they created what are called grade modifiers. And if you have been looking at those videos that I gave you guys on your class schedule, I gave you links of all the videos from the American Academy of Periodontology and the European Federation of Periodontology. You will see that they say, you know something, diabetes and smoking are such, we have so much research telling us about how detrimental that is to periodontal health that we're going to include them as grade modifiers. So if your patient smokes or if your patient has uncontrolled diabetes, you're going to bump that patient up in a category because the grade A people are non-smokers and they have normal glycemic control. However, if you have a smoker that smokes less than 10 cigarettes a day, they are a grade B. If you have a diabetic that has a HbA1c greater than 7, they are a grade B. And then grade C folks are those that are smoking more than or equal to 10 cigarettes a day, and their HbA1c, and also for those whose HbA1c is greater than 7. Let's go back to the PowerPoint, and I'm probably going to say all this again with the PowerPoint. Remember, stage 1, the severity means that we have interdental clinical attachment loss of 1 to 2 millimeters, and remember, it's always going to be at the site of greatest loss. Radiographic bone loss extending to the coronal 1/3 of the root, and there's no tooth loss due to periodontitis. The complexity of management is going to correspond with probing depths that are 4 millimeters or less, and you're going to have mostly horizontal bone loss. If you don't like my cheat sheet and you want to just copy this down, this is a great guide as well. This is telling you my stage 1 patients essentially are going to have this. My stage 2 patients are essentially going to have this. What am I going to see? Well, I'm going to see interdental clinical attachment loss of 3 to 4 millimeters at the site of the greatest loss. Don't forget that. I still have bone loss extending. At this point, though, the bone loss is extending to the coronal 1/3 of the root. So this means what? This means that it's less than 33%. And I still have no tooth loss due to periodontitis. My probing depths are 5 millimeters or less, and again, I have mostly horizontal bone loss. Stage 3 is when it starts getting really interesting because now I have interdental clinical attachment loss greater than or equal to 5 millimeters at the site of greatest loss. I have radiographic bone loss extending to the middle 1/3 of the tooth, and now I have some tooth loss, which means that 4 or fewer teeth have been lost due to periodontitis. My probing depths now, 6 millimeters or greater. I may have some vertical bone loss. It doesn't mean that I have to have everything. My stage 3 patients don't have, this is not a checklist, but how am I going to classify my patient? If some of these things are present, then he's going to be a stage 3 patient. My patient may have class 2 or class 3 furcation involvement, and there's some alveolar ridge defects. And stage 4, of course, is advanced periodontitis, and I really appreciated that they put these in parentheses, okay? Stage 1 is the initial stage. Stage 2 is like established periodontitis. Stage 3 is severe periodontitis, and stage 4 is advanced. I like that. That makes sense. However, advanced periodontitis is not a classification. Stage 4 periodontitis is a classification. Okay? And then, like I said, we're going to go grades. We have to give our patient an extent. We're going to say, at the end of doing all this, what you want to say is the following 3 things. My patient has generalized stage 2 grade B periodontitis. So you need to include those 3 characteristics when you are doing your classification. So there are 3 grades, which are an indicator of the progression. Okay, grading refers to the progression. Staging refers to the severity of the disease. Determine likelihood of clinical. So why we're grading is because we're trying to determine how quickly this disease is progressing. Based on direct evidence, based on indirect evidence. Okay, based on direct evidence, meaning that you have the radiographs there that you can compare, or we can be based on indirect evidence. And if I'm going to use the indirect evidence, that's when I have to take the percentage of bone loss and divide it by the age. Grade A means that there is no clinical attachment loss or radiographic bone loss over a 5-year period. There's a lot of biofilm deposits, but there's really very little destruction. However, remember that this is actually no. Grade A is if my patient is a non-smoker and it doesn't have any sort of diabetic complications. Grade B, however, we do have smoking included in this category. This is for my smokers. If my patient smokes and he smokes less than 10 cigarettes a day, he's going to be a grade B. And then also for my diabetic patients, this is the less than 7 is the qualification. Grade B in general means that there is less than 2 millimeters clinical attachment loss or radiographic bone loss over a 5-year period. And that tissue destruction, the phenotype, is that the tissue destruction is in line with the expectations given the amount of biofilm that's present. And then we have grade C, which means that it is a rapid rate of progression. And if I do have my x-rays, I can use my direct and indirect to let me know if it's 2 millimeters or more or clinical attachment loss. And tissue destruction exceeds expectations. This means that, I don't have this much biofilm. I don't have this, but I do have a lot of destruction. And then, of course, remember your modifiers, your grade modifiers, your smoking, and your HbA1c levels. Okay? So, confirmation. So, periodontal diagnosis is confirmation that a periodontal case should include, remember, it's periodontitis if I have clinical attachment loss at 2 non-adjacent teeth. Whether it is necrotizing, a manifestation of systemic disease, or periodontitis. So you're going to tell me, let's say you have a patient with papillon-Lefebvre. You're going to tell me the extent, which is localized, generalized. You're going to tell me the stage, and you're going to tell me the grade, and you're going to tell me periodontitis as a manifestation of systemic disease. Okay? And then a description of the aggressiveness by adding the stage and grade. So remember, you need to give me 3 major things. You need to tell me if it's periodontitis is a manifestation of systemic disease, or if it's necrotizing periodontitis. And then you have to give me the staging and the grading, and include an extent, which is localized and generalized. And here we have a case study. These are actually the case studies that are in your textbook. Please review them. Please make sure you understand why we're coming to these conclusions that they have. I have reviewed them as well. I'm pretty much in line with them. And then when we come back to class on Tuesday, we will be doing case studies. I will give you the case studies in class because I want you to work through them in class. And I'm gonna try and do some workout groups also next week so that you guys can work together. All right? Have a great day.